Now, the second way we fail the seriously mentally ill is when we mislead officials into thinking we should spend more improving mental health and mental wellness in the masses rather than on treating the seriously ill. As a result of our advocacy, the ability to get care has largely become inversely related to need. The least seriously ill are going to the head of the line, and the most seriously ill are going to jails, they're going to shelters, they're going to prisons, and they're going to morgues. We did that. Now, I know this group favors community spending, and as you can see, that's where state funding is going, reinvestment. Funds have been moving from state hospitals, which by definition serve the seriously ill, to community programs. And this is what's been happening. This is state spending over time. But that's not where patients are moving. Patients are moving from hospitals, which are going way down, to jails, which are going way up. But we in the industry still claim that if we reduce hospitals, we will reduce institutionalization. That has nothing to do with reality. There are people, and by the way, the difference in the totals between 1960 and today is largely accounted by homelessness, so the total institutionalized is roughly the same. Now, we have to start ending this mental illness to jail pipeline. And there are several ways we can do it. We should support hospitals, and that means eliminating the federal government's IMD exclusion, which is federally sanctioned discrimination against the mentally ill. We have to make it easier for people to get treatment before they become danger to self or others, rather than preserving laws that require them to become danger to self or others. And that means we have to stand up against Bazelon, protection and advocacy, the ACLU, radical peer communities, the Center for Mental Health Services, and others who believe being psychotic, delusional, hallucinating is a right to be protected rather than an illness to be treated. And we have to vigorously support assisted outpatient treatment. Now, assisted outpatient treatment is only for a very, very tiny percent of the population. It's for a subset of the 4% who don't voluntarily engage in treatment. And what it allows is it allows the courts to order the person to accept community treatment for 1 year. So they continue to live in the community. It's less expensive, less restrictive than inpatient commitment or incarceration. And as you can see from the chart, it reduces homelessness, arrest, incarceration in the 70% range, and that research holds up wherever it has been used. AOT is not an alternative to community treatment. It is a way to see that the most seriously mentally ill can get into it, and we should be vigorously supporting it.